Any more questions? Well, then it's my great honor to introduce our next speaker. This will be Dr. Alvaro Ibarra from Chile. Welcome, and we're hanging on the edge of our seats to listen to your presentation. We do not hear you. Could you just... We still cannot hear you, but we see you.
Now?
Perfect, we hear you.
Okay. First of all, I would like to thank the organizing committee for the invitation. The pandemic has produced a global health, economic, social, and personal crisis, much pain. But as a positive effect, we have never been so connected before, and this meeting is a demonstration of it. In our days, the review of the material from external biopsy in common breast pathology is necessary. There are frequent disagreements with no or minimal effect on treatment. Important difference in morphological diagnosis are between 80 to over 25%, and in the interpretation of immunohistochemistry markers from more than 3% to over 41%. And nowadays, caring for the patient with breast cancer is multidisciplinary, with a large interactive team. The multidisciplinary team, among others, ensure correct diagnosis in triple approach, with the agreement between the clinicians, radiologists, and pathologists, because they form the core of the will produce adequate staging of the general condition of the patients, comorbidities. They will make recommendation for therapeutic management, long-term control plan, and in summary, they will produce great synergy between all the components of the multidisciplinary team. It should be considered the standard in the care of patients with breast cancer. Strengthens non-technical skills of the participants, based on the trust and mutual respect of the participants. And of course, pathologists play a major role in its operation. We need criterion, experience, a global look, and Professor Juan Rosay produced a lot of very intelligent advantage in our specialty. And one of his sentence is this: the pathologist being able to give accurate, correct advice requires medical knowledge that sometimes transcends morphological skills. But we don't need to carry all the weight, all the responsibility and repeat, the core of this team is conformed by treat on fair basis our patients. The original suggestions of therapeutic management is frequent change by the but an specialized multidisciplinary team in over 40%. The pathological interpretation change are high. And they promote changes in the management of the patient in over 8%. In the media, is very well recognized the importance of the pathological diagnosis in the management of the cancer patients, especially in breast cancer patients. This lady, a health counselor, recognized our role in this form. The most important person on your medical team is someone you will probably never meet, your pathologist. The surgeon and oncologist will base many of their therapeutic decisions on the information provided by the pathologist. But at the same time, she remarks, so your life depends on the accuracy of the pathological report. How do you know if this is correct? Do you need a second opinion on your biopsy? In the media, it's very frequently to find reference about the importance of the second opinion. And the legal problem is another edge. Fortunately, our peers have worked a lot to objectify the real theme, putting in a objective and real dimension the problem. All of the above goes to the benefit of the best management in each patient. The tissue pathological diagnosis determines the surgical management and the eventual use of complementary therapies. The increase in the incidence of breast cancer, especially carcinoma in situ, due to increased imaging studies, has increased needle biopsy of small and atypical lesions. Reliability in pathological diagnosis allows ensuring correct decision making. In our work, the material was from 2012 to 2019. The great majority of the specimens were biopsy, corn needle biopsy, 150. And the great majority of the material we received were slides and inclusions. Only one cytology and 76 immunohistochemistry of prognostic predictive factors. We classified the cases in benign and malignant. In the benign group, we included atypical and borderline lesions. In malignant, we included intraductal carcinomas, intraepithelial neoplasms with microinvasion, and invasive carcinomas. We considered major morphological disagreements when we change benign to malignant or vice versa. When we change intraepithelial neoplasm to carcinoma with microinvasion. Intraductal carcinomas to invasive carcinomas, or invasive carcinomas to intraductal carcinomas. Major discrepancies in interpretation of immunohistochemistry of prognostic predictive factors in hormone receptor when we change from positive to negative or vice versa, or when we found
Dr. Alvaro,
differences. Yes.
excuse me, I'm sorry to interrupt. Could you please share your slides? Is that possible? You can go to the line at the top of your screen, and there you see share.
Now it's okay.
No, it's a green icon. Here I see it. It's a green icon
Yes.
at the bottom of your screen, and then you can share your screen.
I put in the green bottom. Excuse me.
Has your screen a green border?
Yes. Yes. Oh, so sorry.
It's all right. We'll manage that.
Excuse me. Can continue without the share screen? I really so sorry.
Well, anyway, if it's impossible, just continue. At the beginning, I wasn't sure whether there are any slides, but just go further on, please.
I previously shared with the organization my presentation. Excuse me, but now I can't to share the presentation. I don't know the reason.
Okay. No matter. Just go ahead. We can follow you.
Okay. I told about major discrepancies in hormone receptors when we changed positive to negative results or vice versa, or when we found differences greater than 50% in the score. In HER2, when we changed from positive to negative or equivocal, or the negative, or from negative to positive or equivocal, or from equivocal to positive or negative. And in KI 76, when a score less than 20% was changed to 20% or more, or when the score differences were greater than 30%. Our results and diagnostic difference over 15%, but major discrepancies we found in 11%. In histopathology findings, features, about 5%, and in immunos interpretation, almost 30%. In the diagnostic change, in 5 opportunities, we change benign to malignant. 2 cases from ADH to DCIS. In 1 opportunity, papillary complex lesion to DCIS. Microtubular. No pude compartir las imágenes.
¿Dónde está la reunión?
Aquí.
Ya, póngala ahí.
Y le puse ahí. Pero no me dio la palabra.
Está abierto esto. Es que aprieta ahí. Ah,
No importa.
ya.
Excuse me. From papillary complex lesions to DCIS, from microtubular proliferation to ductal invasive carcinoma, and from lobular intraepithelial neoplasia grade 2 to the same diagnosis but with microinvasion. We change diagnosis from malignant to benign in 3 opportunities. DCIS to ADH in 2 cases, and DCIS to ductal proliferation, not ADH. And in 1 case, we downgrade the diagnosis from ductal invasive carcinoma to ductal intraductal carcinoma. Major divergences in interpretation of immunohistochemistry in hormone receptor was in 8 opportunities. We change negative to positive in 6 cases, and positive to negative in 2 cases. In HER2, in 5 opportunities. From negative to equivocal, 3 cases. Equivocal to negative, 1 case. Equivocal to positive, 1 case. In KI, 76 in 5 cases. Score changes of less than 20% to 20 or more percent, 5 cases. The difference was in 7 cases. And a score difference greater than 30% in 2 cases. Discussion. The specialized review service has quality control in surgical pathology. Most pathologists correctly diagnose 80 to 90% of cases. Classification into large categories, for example, benign versus malignant, has good inter-observer agreement. This is valid for breast pathology when included within the benign lesions, the atypical borderline. The diagnostic variation between the external reports and those of our team is within expectations, both in histopathology and immunohistochemistry determinations. The multidisciplinary study of clinicians, imaging specialists, and pathologists with the knowledge of what the second opinion can contribute makes the management of these patients safer. In my almost last slide, sorry for not sharing in direct form, I put some historical articles. One of Beers from 1979 with almost 11 of cases diagnosed as invasive carcinomas were not. 4 different articles up from 1995. Sales 2008 and Marco 2014 mention that error between 0.25 and 16%, on average about 8%. The errors, the mistakes are greater in borderline lesions, DCIAs with microinvasion, and lobular neoplasms. And Snish from the MD Anderson, Sales and Elston mention that well-defined criteria and focus workshops reduce reproducibility failures. Joint work of the multidisciplinary team with high confidence in its members give our patients the best chances to face their future. Thank you so much for your attention. The best and warm greetings from Chile. Please see our images from the platform of the meeting in the next futures. Thank you so much.